Namaskar and good evening, everyone.
And this was the peculiarity in the exon 20 insertion mutations, but they found that they have a very low tumor mutation burden. So as compared to, you can see, as compared to the del 19, the TMB of the exon 20 insertion mutation is low, and it is also very significantly low compared to the whole population in which there was no exon 20 insertion was found. And the PDL1 association was also seen that the negative PDL1. So if you see this exon 20 insertion category, so they had a very found a very strong association with the proportion of the patients with having the PDL1 negative. So the blue bar is showing the PDL1 less than 1%. So the maximum patient were having the PDL1 negative in this exon 20 insertion mutation category as compared to the category in which there was no exon 20 insertion was seen. And these are the curves showing the clinical features and the response to treatment. So this dotted lines are basically the EGFR exon 20 insertion mutations, and this solid line is the NSCLC without any targetable alteration. So they were compared. So they found that the patients with the exon 20 insertion mutations, they have a comparatively better survival as compared to the patients in which there was no targetable alterations were identified in NSCLC category. And the graph B is showing the time to discontinuation of the treatment to the chemotherapy. So those patients in which there was no targetable alterations were identified, the solid line, the time to discontinuation of the treatment was shorter as compared to the exon 20 insertion mutation. Whereas when the patients were subjected to the immunotherapy, the immune checkpoint inhibitor, so you can see that the time to discontinuation was very short and steep for the exon 20 insertion mutations. Coming to the testing methods and treatment for the detection of this exon 20 insertion mutation. So NGS or the multi-gene assay is now actually recommended because the heterogeneity of EGFR exon 20 insertion mutation is quite high, and the PCR has very poor sensitivity, and it is not at all recommended. And there has been studies, and one study has even shown that even 50% of these exon 20 insertion mutations were missed when they were tried to be picked up on the PCR platform. So PCR should be avoided for this, and NGS is the recommended modality. The two targeted therapies that has been approved by US FDA, that is the amivantamab and mobocertinib, and they are approved for locally advanced or metastatic NSCLC harboring these EGFR exon 20 insertion mutations that has actually progressed after the prior chemotherapy. But recently, we have found the very encouraging results in this Papillon phase 3 global study, in which the role has been found even in the first line, but in combination with the chemotherapy. So this was the study design in which the eligibility criteria was a treatment naive locally advanced or metastatic NSCLC with a documented EGFR exon 20 insertion mutation with a PS0 or 1. And total 308 patients were recruited, which were divided into 153 and 155 patients for the combination and alone chemotherapy respectively. And the primary endpoint was the PFS, and the secondary endpoints were the overall response rate, the duration of response, and overall survival. So we can see here that the blue graph is representing the amivantamab and chemotherapy combination, and we can see there was a very good prognostic separation of the curves in terms of the progression-free survival by BICR as compared to the gray curve, which is the chemotherapy alone. And so was the case with the duration of response by BICR, and you can see that the blue curve again showing a very good prognostic separation and a better prognosis as compared to the chemotherapy alone. Besides this, there are other uncommon EGFR mutations like exon 18 G719X, exon 20 S768I, or exon 21 L861Q. And this was the important publication in which these uncommon EGFR mutations were also explored, and they found that the 37 patients which were enrolled, they demonstrated a favorable activity of osimertinib with the manageable toxicity used for these harboring uncommon mutations, because these mutations they don't respond to the first generation TKIs. And this was the largest cohort that has been studied till date, in which the treatment outcome of the atypical EGFR mutation in the German National Network Genomic Medicine Lung Cancer. And it was a multi-center study comprising of 856 NSCLC cases with atypical EGFR mutation, including the co-occurring mutations that were reported from across the 12 centers. And the clinical follow-up data after the treatment with a different EGFR TKIs, chemotherapy, and immune checkpoint inhibitors were available from 260 patients. So the response to treatment was analyzed in the three major groups. The first was the uncommon mutations, which I have just alluded in my couple of slides back. So here what they found that there is a higher efficacy of the EGFR TKIs in comparison to chemotherapy, especially to the osimertinib. Whereas exon 20 insertion mutations, most of them, they were not EGFR TKI responsive, including osimertinib. And very rare EGFR mutations, like very rare single point mutations, compound mutations, or exon 18 deletions or 19 insertions. So the response rate to these, to the EGFR TKIs, was very heterogeneous because the study population in the various categories was very small. So we know that these mutations, they are quite often missed in the PCR. So now NGS is now much preferred over the single gene assay as a testing modality. And why it is important? Because it is tissue proficient. Even a 10 nanogram input of DNA and RNA is good enough. It's also a resource proficient. It's a one test, one experiment, one platform. The variant allele detection cutoff is around 5%, hence it's overcome the problem of the low tumor fraction, which we do get across in our practice. And it maximizes the detection of the actionable and other driver mutations. Like you can classify the alterations like a tier 1, tier 2, and tier 3 alteration, and based upon the category, patient can receive the targeted therapy or can be recruited in the clinical trial, which is a need of ours. And NGS, the bigger strength is that it can use even a plasma as a sample. However, turnaround time is still a problem. So coming to the emerging technologies, the advancements in the precision medicine, liquid biopsy, and artificial intelligence are transforming the landscape of NSCLC treatment. The next generation sequencing platforms enable the comprehensive genomic profiling for identifying the rare mutations and treatment targets. And integrating the molecular data with the clinical outcomes is advancing personalized medicine in EGFR mutant NSCLC. The treatment decision in the EGFR mutant NSCLC should be based on the multidisciplinary approach involving the oncologist, pathologist, and molecular biologist. The patient preferences, performance status, and comorbidities should be considered when selecting the treatment options. The regular monitoring of the disease response and molecular changes is crucial for adapting the treatment strategies. And regarding the participation in the clinical trial is essential for advanced treatment options in the EGFR mutant NSCLC. Investigational therapies targeting the novel pathways or resistant mechanism offer hope for the patient with a refractory disease. And for this, the collaboration between the researchers, clinicians, and patients is the key to driving the innovations in the NSCLC treatment. So to conclude, there is an extensive role of biomarker testing in metastatic or advanced NSCLC, especially adenocarcinoma. The broad molecular testing, NGS, and liquid biopsy have already made their place for the biomarker assays, and the multidisciplinary communication is essential for the quality information within the required time frame, that is the turnaround time, and that too at the judicious cost. And it's incumbent upon pathologists to make the testing reliable by optimizing all the three steps, that is the pre-analytical, analytical, and post-analytical steps. Thank you so much.
Thank you so much, Sunil sir. So, wanted to know which panel at Rajiv Gandhi are you doing? Is it a hotspot panel or you are straight up going for a deep sequencing? What's the usual practice over there for CL NSCLC?
Okay, so we have devised a smart, the panel name is the Smart Lung panel. So what we are doing is that, so it takes care of the cost as well as the turnaround time. So here what we are doing, that a 32 gene panel has been devised, but the sample when it comes, so we are immediately we are subjecting once the diagnosis is confirmed that it is non-small cell carcinoma, so immediately the ALK is done by IHC and EGFR we are doing by PCR, and so that the most common mutations are being taken care within 3 to 4 days. Whereas after 2-3 days, the sample will be subjecting for the NGS also. It is done by both the DNA based and RNA based sequencing. The RNA based sequencing is more appropriate, and it is accurate for the rearrangement especially, whereas the DNA based sequencing is more appropriate for the point mutations and all that.
So thank you so much, sir, and for your wonderful insight on this difficult topic. So I will be inviting our next speaker, who's a dear friend and a colleague, Dr. Rajit Chanana. He is a consultant medical.
Very much for this invitation. I think the Tarun's team has the slides. So can they be shown by the team? So can you please share the slides? Show the slides from your end, Tarun. So I think my job has been made a little easier by Dr. Pasricha.
Sir, we don't have your slides. Can you share with me, sir?
Array, I sent it 6:30 to Tarun. Where is Tarun?
I think Sir Tarun is in Bombay. He has not joined.
He called me, na? Ek second. So I don't know how to do this. So normally they share by slides all the time.
You can share it with me. I will do the necessity.
Hmm.
You can share it with
Okay.
me. I will just forward it.
So I've sent them to you. I mean, they're going.
Yes, just a second.
Yeah.
So you sent by WhatsApp, right?
No, by mail.
By mail. Okay. We have the slides.
Shyam sir, I have shared your slides.
Okay. Am I audible?
Yes, sir, but your voice is echoing. I think there are two devices, maybe.
Welcome to Sonolux Universe. The Bluetooth device activation tab.
Hello. Hello. Is it okay now?
Yes, sir. It's okay now.
Sorry for this glitch,
Yeah.
So I think this is a sponsored session and the slides are coming from the Janssen. So I think the hidden EGFR threats are sort of beginning to be recognized because we do have agents which can target these EGFR aberrations, which are not amenable to the TKIs, which have actually ruled the roost, and they are still going strong even after 15 to 20 years. So can we have the next slide? So, lung cancer remains a huge unmet need here. As you can see, that the incidence is small. I mean, small in the sense that 12.2% in the US. But if you look at the mortality, so that is still very high as a result of lung cancer. So 20.8% of all cancer deaths are because of lung cancer. And this is because, next slide, it tells you because the patients are usually detected in advanced stages, and we still have a long way to go in terms of our ability to prevent deaths from happening. So we certainly have been able to increase their survival, but then the 5-year survival for these patients still remains low. Next slide. Can we have the next slide, please? Right. So, this is to show that particularly, adenocarcinomas of the lung, I mean, they have the, driven by a particular oncogene, and there is an addiction to that oncogene, which makes this, cancer amenable to that particular drug, which can target the actionable mutation and therefore, improve the progression-free survival and to some extent survival in these patients. And so the targeted therapies have really come in a big way, particularly in adenocarcinoma of the lung. Next slide. So next slide, please. So focusing on the EGFR and exon 20 insertion mutations. So I think the EGFR pathway basically, is looking at the cell in conjunction with other, genes, which I mentioned here, for example, PI3K alpha or PLC, delta, CBL, etc., which, help the cells to grow, to metastasize, and to prevent apoptosis and reprogramming the metabolic networks. Next. So this is the story of EGFR mutations in patients with metastatic non-small cell lung cancer. So as you can see, EGFR aberrations are seen in about 28%. So this is a slide from the West. I think you're going to be seeing, and we do see a higher number in our part of the world and in the Japan, China, and Korea, etc. The other, abnormalities are seen in the KRAS around 25%. So I think those are also targetable. We do have some drugs, but then not available. But then the other common abnormalities are relating to ALK, B2, MET. I think you all know all these. So these are in smaller numbers. So we're going to focus on EGFR. Next slide. Demonstrates that, out of those 28% of EGFR mutations, almost 46 and 38, which is contributing around 84%, are in exon 19 and exon 21. And in exon 20, which is what we want to focus on, is seen in about 9%. And there are other uncommon mutations in exon 18 and exon 21, which are, say, less than 6-7%. So our focus is on exon 20 insertion mutations, which are seen in 9% of 28%. We'll come to the figures. Next slide. So these are certain, insertion points, which I'll show you in the next slide. So if you see here, the exon 20 insertion mutations occur within the tyrosine kinase domain. And this is the, as you see, the tyrosine kinase domain here. So 19, 20, 21. The common abnormalities are in exon 19 in the form of deletions, and L858 are in exon 21, which, as I told you, is contributing around 85% of all the mutations or deletions happening in the EGFR. So in exon 20, the uncommon EGFR mutations, as they are called, and uncommon mutation in exon 20 insertions occur in, C helix or loop following C helix. So in-frame insertions in exon 20 of EGFR gene were among the first EGFR mutations to be identified as oncogenic drivers in NSCLC and account for about 12% of EGFR mutated NSCLC. So the next slide also gives you these are various points where the tumor. No, go ahead. Yeah. So these are various sites where the tumor, as you can see, in the helical region, in the near loop region, and in the far loop region. So these are either in the form of in-frame insertions or duplications, and most insertions comprise 3 to 21 nucleotide base pairs, which is 1 to 7 amino acids, and the location of these insertions can influence drug and ATP binding kinetics. So, I mean, there are different exon 20 insertions, as you can see here, and most of them are happening between 761 to 775 amino acid. And depending upon the site, they can be very helical, near loop, or far loop. Next slide. So these, exon 20 insertions will determine the sensitivity to the TKI therapy. So unlike your exon 18, 19, and 21 abnormalities, the exon 20 mutations are typically resistant to the pills, the EGFR TKIs. Exception is there, which is, I think Sunil also mentioned, A763, underscore Y764. So one can, one needs to look at the report more carefully, that if you have this particular insertion, well, then this could be responsive to a TKI. The others insertions are not, responsive to TKIs. So this is, they reduce these insertions or mutations. They reduce the TKI binding, except for the mentioned here. And the low response rates, 3 to 8% have been reported to the erlotinib, gefitinib, and afatinib in patients with the common or most of the EGFR exon 20 insertions. So I think therefore they need attention in a differential fashion, and therefore the importance of this particular driver mutation, because the cells are dependent on this insertion mutation for their survival and for their metastasis. Next slide. So basically, the exon 20 insertion, leads to a reduction in the size of the drug binding pocket and the affinity for TKIs, indicated for common EGFR mutations. So you can see the difference in the, the pocket where the TKI is supposed to bind. It's different between the two, whether the patient has a deletion or an L858R. So that's the reason, so that at the three-dimensional level, the drug cannot, get into that slot where it is getting in patients where, you have exon 19 deletion or L85R mutation. And there's less affinity for ATP. So I think it basically gives a different, site and a different affinity for the TKIs. Next slide. For the exon 20 insertion. And that makes it different and distinct. Next slide, please. So coming to the prevalence of exon 20 insertion mutations, you can see in China, Japan, Taiwan, the figures are hovering around 1 to 5%. Next slide. So not common, but not rare either. So we do see patients, and I think we all are seeing. So there are limited treatment options, as you can see, platinum-based in combination with IO or agents. You can see the PFS for such patients who have exon 20 insertion. So, it is quite low. As you can see, the PFS is only with TKI 2.9%. With IO alone is 3.1%. I think the best outcome seems to be with platinum-based chemo in terms of PFS, and the overall survival going up to 17.4 months. So, this tells us that this disease is different and maybe not that responsive to therapy than as compared to patients who do not have exon 20 insertion. Next slide. Next slide, please. Next, please. Okay, sorry, this is the second line. So I think the data again shows that you have, much lower kind of response rates, and there is no standard of care. As even in the second line, the TKI is only giving you 2.5 months of PFS, and I mean, it does give you some 14 months, but there is no clear-cut, standard of care for the second line. Next slide. So platinum-based chemotherapy is recommended for first-line treatment for EGFR exon 20 insertion mutation with a median PFS of 5 to 7 months. And if you see, the overall survival with platinum-based chemo is, as I showed you, 17 months. With TKI alone is 9.5. With IO alone is 12.1. So I think suffice it to say that these patients do best, I think, with chemotherapy in the first line. But I think there are new changes and new guidelines for treating such patients since March 2024. So next slide. So this is the median PFS, as we all know, for sensitizing mutations. This is hovering around 12 to 14 months when it comes to first and second generation TKI. But then with the drugs like osimertinib, the PFS is going even up to 19 to 20 months. But in contrast, the exon 20 insertion mutations, they do pretty bad with the TKI, as is seen here, less than 2 months. Next slide. So therefore, in view of these kind of results and data, for common EGFR mutations, the TKI is recommended, but for patients in the first line, but for patients with exon 20 insertion mutation, systemic therapy like, a chemo with or without IO is recommended. And of course, as I said, the guidelines have changed. Maybe these are old slides which have been given to us. Next slide. So this is what I said, that patients with these insertion mutations have a poorer prognosis than as compared to common EGFR mutations. And the next slide will show you the curves demonstrating or maybe the data here. So I think it's also important to remember that in a large cohort of patients, exon 20 insertion, is the third most frequent EGFR mutation after, L858R and exon 19. And they are insensitive to EGFR TKI. So, it is an unmet need, which seems to be, now addressed by the availability of a suitable, inhibitor. Next slide. Okay, so this is the real world data for patients. If you look at the overall survival for these are the patients of common EGFR versus EGFR insertion. So the outcomes are inferior in terms of in this large cohort of patients who were sort of looked upon. 75% increased risk of death. Next slide, with a significant p-value. Next. So again, the PFS data again shows that the curve for the exon 20 insertion mutations is much inferior than as compared to the common EGFR. Next slide. The 5-year survival rates for the insertion patients are 8% as compared to 19%. So these are again showing you the poor prognostic value of the EGFR exon 20 insertion. Next slide. So how do you test? I think Dr. Sunil did cover a few slides on this. Next slide. So I think the current physicians are using at this point in time, testing, which includes a variety of abnormalities, such as, the common EGFR mutations, including exon 20 and BRAF, ALK-ROS, and others like KRAS, RET, MET exon 14 skipping mutation. So I think we need to look upon all these, especially, for adenocarcinoma. Next slide. So I think we've just gone beyond this now because the patients need to be tested for this. Next. So one can look at the tissue preferably, and if the tissue is not available, I think the liquid biopsy is also in vogue for such patients. The diagnostic testing drives patient selection for targeted therapy and offers many advantages because, I think we all are aware that targeted therapy is giving better outcomes than as compared to chemotherapy. Next slide. So this is the old way of looking at things, PCRs. Then, of course, the next generation sequencing, which can use either a hotspot panel, or today, I think the preference is for a comprehensive, gene profiling, even for 10, 15, or 20 such genes. This is what Dr. Sunil was mentioning. And, but then, and the tissue is, as we all know, an issue many a times because splitting the tissue for PCR and IHC sometimes may not be possible because the tissue is so tiny. So NGS is resorted to by most of the physicians. However, the Rajiv Gandhi have a different protocol because they do the PCR and IHC for EGF, common EGFR and ALK, and the rest of the tissue is sent for the NGS, which is for more than 20 genes. And then it takes about 15 to 20 days for the reports to come in. Next slide. So the importance of, NGS lies here, as you can see, that the pickup rate for EGFR exon 20 insertions is more than 70%. And therefore, a targeted PCR-based approach for detection of EGFR variants may underdetect EGFR exon 20 insertion mutations, and the NCCN recommends NGS-based strategies. So, if you really want to pick up the exon 20 insertion mutations, you should be looking at NGS and not for a PCR, because as I showed you, the insertion is at several points, and you need to have a large number of PCR panels, which is not usually possible. Next slide. Because there are several of these, the commercial PCR kits are unable to identify approximately 50% of EGFR insertion mutations, and therefore, and the foundation, is able to pick up a large number of mutations. So I think you need an NGS. The answer is very, very clear if you really want to focus on EGFR 20 insertion mutation. Next. And this is also supported by the guidelines, which are the CAP guidelines or NCCN guidelines or the Indian consensus. So newer gene mutations may be included in the frontline testing panel, depending on the availability of targeted therapies. I think most of the drugs today are available, and therefore either you go for a reflex testing or one can go for a broader molecular profiling, upfront by the NGS, and that should be also be preferably, not a hotspot panel, a comprehensive genomic profiling, which picks up all the abnormalities in the genes which we want to study. So I think this is NGS seems to be the order of the day. Next slide. And it should be multiplexed or, a comprehensive gene. So this is the point I was trying to make, that if you add plasma to the tissue, it increases the detection of actionable mutations and improves treatment delivery. So detection of actionable mutations increased from 20 to 35 or 36% when plasma was added to tissue. So, we all been thinking that we should do both, but then the cost does come in the way. But I think if somebody can afford, if you don't pick up on the tissue, I think the plasma NGS can pick up an extra, 15% or so mutations, which can be relevant to that particular individual. So should it be mandatory? Should it not be mandatory? That can be discussed because the cost is a factor, because when you do add for plasma, the cost does come in the way. But I think as a reflex, if you have a lady, if you have a adenocarcinoma, a strong suspicion, then one can look at tissue if negative, followed by plasma. Next. So I think for patients with under certain circumstances, the plasma tumor DNA testing is recommended. If the patient is medically unfit for testing or insufficient material, and if the feasibility of timely tissue-based testing is uncertain, one can look at the CFDN. Next slide. So what about the Indian scenario? Again, you see the from various centers, the incidence of the exon 20 insertion is 1 to 8%. Next, the maximum is from Tata, from Nornoha. So only 2 retrospective studies are reported for efficacy, and the CATE study insertion PFS of 6 months and the median overall survival of 15.8 months. In the same study, the median PFS with oral TKIs was very, very poor. And Nornoha study, reported a dismal overall survival of 5 months in patients with EGFR exon 20. So, highlighting that the prognosis of this particular driver mutation in lung cancer is quite bad. Next. So now coming to the drug which has become available to us, which is amivantamab. Next. So this is an interesting drug because it is a EGFR MET bispecific antibody. So as you can see that there are 2 binding sites here. So MET binding and EGFR binding, the green and the blue one. And since we are focusing here on EGFR mutations or insertion 20 mutations, so this particular drug is focused on EGFR binding. And by targeting these 2 resistant MET mutations and EGFR mutations, amivantamab addresses 2 major mechanisms of resistance in standard of care. So I think this is the old guideline, which states that patients are approved for amivantamab once they're progressed on chemo, when we are looking at exon 20 insertion mutation patients. Next is the old guideline. So this is interesting. I learned something new. Amivantamab has demonstrated 3 mechanisms of action. So this is quite simple here, that if a tumor is having the EGFR mutation, so the drug will bind here to the tumor cell, or if the patient has MET alteration in the form of mutation or amplification, the MET antibody will bind here and look after the tumor. But there's another term which is called the trogocytosis, cellular gnawing. This is immune cell directed activity. So where the macrophage or the natural killer cell, the antibody gets into these macrophages, or it binds to the natural killer cell, and then subsequently, it's different from phagocytosis. In phagocytosis, the entire tumor cell is taken up by the macrophage. Here, piece by piece, or a part of the membrane of the, as you can see, a part of the membrane is being, sucked into the macrophage. And so, the antibody then binds to the receptor degradation happens. So I think there are more slides to this. Trogocytosis also contributes to receptor degradation, so which is responsible for tumor cell kill. Next slide. So the lysosome also has a role to play. As you can see, maybe the next slide has, so this is trogocytosis, where monocytes and macrophage, they are looking at the cell in a piecemeal kind of a fashion. And again, the activated NK cell, gets the antibody, and they express the antibody, and then they look at the target cell. So the perforin and granzymes kill the target cancer cell. So this is, ADCC coming into play when we are looking at immune cell-directed activity when we are giving this antibody. Next. So this is the receptor degradation, and the tumor cell, and the antibody is then looking at the tumor and killing the tumor cells through receptor inactivation. So I think in addition to the direct activity, there is a antibody-mediated drug site toxicity, so which also is killing the tumor cells. Next. So I think this is the direct inhibition of by ligand binding. Next, and looking at the downstream signaling. Next. Can I have the next slide, please? Okay, so this is another important slide because the drug is relatively new. Can I get the previous slide? Which talks about the dosing? Yeah. So I think you're going to the next slide. So I think let's focus here on the dosing itself. So this is the phase 1 trial, the Chrysalis phase 1 study, and in the subsequent approved doses, if you look at that, 1050 milligram for a person who is less than 80 kilos, and for more than 80 kilos, 1400 milligram amivantamab. So this is the way it is given. Day 1, 2, because the first dose is split into 2 parts. So if you have to give 1050, then 350 on day 1 to look at the sensitivity and hypersensitivity, and the balance dose is given on day 2, which is the the balance dose out of 350, which will be 700. So it's a 350 milligram vial, and so given weekly for 4 doses, and then every 2 weeks. So this is how the Chrysalis has been designed in several indications. So I think we are just going to focus on the next slide, on the exon 20 insertion patients. So this is the study. This is the cohort of patients who had, as I showed you, these patients were, after the exposure to platinum, were given as a single drug, the amivantamab, 4 weekly doses followed by fortnightly doses. Depending upon the weight, the dose was decided. Next. So this is the you can see 81 patients here, and all of these patients had received chemotherapy, and 46% had immuno-oncology, and some of these patients were also exposed to the EGFR TKI, and a few patients had brain metastasis. 17 months from the initial diagnosis. Next slide. So the side effects. So I think since we are targeting two receptors, EGFR and MET. So EGFR related, as we all know, stomatitis, rash, pruritus, or skin toxicity, and MET related are hypoalbuminemia or peripheral edema. And there can be other, infusion related reactions like, grade 3 or more in 3%. So other than these side effects, there were no, AEs leading to death, as you can see here. So nearly 16% patients had more than grade 3 AE. So it's pretty well tolerated. Next slide. So I think I'll just skip this because these are EGFR and MET related. So diarrhea can also happen, but usually it is less than grade 3. Next. So this is the efficacy by the blinded investigator. You can see the response rate in patients who have been pre-treated with chemo, IO, and the EGFR TKIs, and the clinical benefit rate is 74%. So nearly 36% patients had a partial response, and the duration of response was not small, 11.1 months. So which is quite reasonable in the second or third line for that matter. So it doesn't matter whether the patient has been exposed to immuno or EGFR TKI. Next. So this is to show you that the patients who responded, these spider plots are really staying low for months together, as you can see, 18 months and going even up to 2 years. So 47% of the patients remain on treatment at the time of data cutoff, which is quite good. 63% patients had responses of more than 6 months, and the median PFS was 8.3 months, and the overall survival was 22.8 months. So this is in the second, third, fourth line. Next. And as per the, if you see here, these purple bars or the orange bars, I think they have a similar kind of response, but it seems that the near loop ones have a better overall response rate. and the blue ones even better, 100%, but the numbers are small here. So I think maybe the data is for a very small number of patients, but it seems that all subgroups tend to derive benefit. Next slide. So I think to summarize, tolerable safety profile. If you see here the treatment-related discontinuations were very low, 4%, and 40% ORR with the duration of response 11 months, and overall survival of 22.8 months. So pretty interesting drug, though expensive, but I think does have a promise for patients who are found to be having exon 20 insertion mutation. I think that was the last slide. So I think next. Okay. So there's some real world data also. Next slide. And this is the Concert AI. Next. So again, showing you that the higher overall response rate and low risk of progression in the chrysalis versus real world data. So I think you have a similar kind of outcomes. Next slide. So I think we summarize it here that these patients they have a new drug which can get hold of the insertion mutation in the exon 20. Next. Yeah, so I just want to end it by saying that this was the data in the second line, but I think Sunil did mention, I don't know if you have more presentations on the Papillon study on the basis of which the drug was combined in the first line with PEM carbo and has been approved in March 2024 for the first line. And I think that's where we've started using this molecule in a couple of our patients.
Yeah, thank you so much, sir. And obviously, because since March we have been using it since with the combination with chemo. So I think we have to see the side effect profile. We have to be aware throughout the treatment, and these are those side effects which if you don't have any suspicion, I think we can easily miss it out, and even sometimes patient try to hide these kind of side effects. So I think one should be on high alert whenever they are using these kind of medicines.
Right. So one of our patients did have, skin toxicity, and that was, I think, significant, and we may have to reduce the dose by 1 notch. And I think the patient is doing well. Otherwise, the 2 patients whom we have used in the recent past, I think the results are quite encouraging. Maybe early days, but then I think we are quite happy with the outcome. I wish
Yes.
it was less costly, so that one can perhaps use it in a little
Yeah.
larger pool of patients.
Yeah. So thank you so much, sir, for giving this wonderful
Thanks for the opportunity. Yeah.
session on exon 20 mutation. And now we'll be moving on to the next session, which is going to be taken by Dr. Aruj Dhyani, who is a medical oncology consultant at Fortis Noida. And he's a dear friend, and I think he'll be delivering the talk on optimizing treatment in advanced EGFR mutant lung cancer. So over to you, Dr. Aruj. Welcome.
Yeah, hi. Thank you so much. Thank you, Aditya, for inviting me. And thank you, AstraZeneca, for having me for this platform.
So just a heads up, we are running little bit short of time, so you can just see.
Yeah, I'll just straight away come to the presentation.
Yeah, thank you.
Yes, good evening, everyone. So, are the slides visible?
Yes, sir.
Yeah, so thank you, AstraZeneca, for the slides. This is the disclosure that the slides have been prepared by them. I'm just presenting them. And thank you, Aditya, for this wonderful plan. And it's a very crisp program that you made. So I'll be talking about the optimizing treatments in advanced mutated EGFR mutated lung cancers, only in the advanced setting, not in the adjuvant setting for the early carcinoma lung. So EGFR mutation, it's been covered in length and breadth previously, and we all know that EGFR mutation is of the order of 40 to 20% in the patients from the Asian and non-Asian patient population. In our patients, usually we see that around 20 to 23% of the patients who would be having carcinoma, adenocarcinoma lung would be harboring EGFR mutations, and the most common mutation being exon 19 and exon 21. The third most common would be, as like so said, that exon 20 that we know that would be refractory to the TKI treatment. So first generation, second generation, third generation. So we are sitting on the third generation of the EGFR TKI, and of course the efficacy, the spectrum, and the side effect profile, they all vary among the spectrum, among this spectrum. So first generation TKIs being erlotinib and gefitinib, and they used to work by inhibiting the EGFR. That means that the binding was reversible type, and of course they were not active against the T790M mutated EGFR. And then came the second line TKI that were afatinib and dacomitinib. So the beauty was that it was just not that EGFR; it was whole OB family that they were blocking, and the binding was irreversible covalent binding. So the activity was broader, and they tend to circumvent some sort of TKI resistant in the EGFR. But the game changer came to be then osimertinib. That was the third generation TKI. It is EGFR mutant specific inhibitor. It is against irreversible covalent binding to the mutant specific type of EGFR. And of course, it covered the most common mutation that was T790M, which renders the EGFR mutated cancer cell resistant to the TKIs. And thus, this led to the widespread trial and widespread usage of the drug. So structurally, what we see that osimertinib is a bit different from the first and the second generation TKI, and the binding and the ability. The most important part is the ability to cross the blood-brain barrier. So there were two most important things. One is that it will act on the T790M, and second, in the ability to cross the blood-brain barrier was significant with osimertinib. So it inhibits T790M, exon 19 deletion, L850R, but however, the activity is low in again the cases where there are wild type of EGFR and it crosses the blood-brain barrier. So now, over the time, osimertinib has been established as a new standard of care in the first line setting with the patients who have advanced stages of the EGFR mutated lung cancer. The trial that led to the foundation of this was the FLORA trial. We all know that it was a randomized double-blinded phase 3 trial that was there to study and assess the safety and efficacy of the osimertinib in comparison to the standard of care TKIs and the first line setting in the patient that were locally advanced or metastatic. So the mutations were of two types mainly, that were exon 19 and 858R. Patients should not have had received any of the prior systemic therapy, and the performance would be 0 to 1. The stable CNS metastasis at the baseline were allowed, and the doses of osimertinib is 80 milligram once in a day, and the randomization was 1:1. And the EGFR TKI standard of care being gefitinib and erlotinib at a dosage of 250 milligram and 150 milligram once in a day. And all the patients were assessed by the RECIST 1.1 criteria every 6 weeks until there was an objective progressive disease. And the important part is that the crossover was allowed. That means that in the standard of care arm, if some patient had progressed on the TKI, the patients were allowed to cross over to the new drug, that is the osimertinib. They did stratify these patients based on the mutation, that is exon 19 deletion and 858R, and on the basis of the race, that is Asian versus non-Asian. The main primary endpoint of this study was progression-free survival, and that was based on the investigator assessment. And the secondary endpoints being objective response rate, duration of response, disease control rate, depth of response, and the overall survival, and of course the safety. So this is the PFS data for this study that beautifully demonstrated that at the end of 2 years, the median progression-free survival was 18.9 months for osimertinib compared to 10.2 months in the standard of care arm, and the hazards ratio being statistically very significant, being of the order of 0.46. And this PFS was the direct measure of the drug benefit, and this study was basically powered to measure the PFS. So it did make a huge mark. The difference was of a significant magnitude, and from this point, osimertinib came into the bigger picture. It came to be the category 1 drug in this setting. So looking at the subgroup analysis, that in which subgroups the drug did best. So based on the gender, age at screening, the race, smoking history, metastasis, baseline metastasis, EGFR mutation randomization 19 versus L50R across the board, it proved out to be that it was significant and had significant benefit compared to the standard of care arm. Now, this is the overall survival data at the completion for 3 years. So overall survival, that was a median survival, and the osimertinib arm was 38.6 months compared to the EGFR, or the comparator TK arm, that was 31.8 months. Again, this difference was also significant, statistically significant. So the patients who were taking osimertinib were more likely to be alive at 2 and 3 years landmark. And this was for the first time that an EGFR TKI has translated this PFS benefit into definitive significant OS benefit. So at the completion of 3 years and beyond it, 28% of the patients were still receiving osimertinib, compared to only 9% in the standard of care arm. That was the previous TKIs, that is gefitinib and erlotinib. So this is something that was significant at the end of the 3 years. So, and other thing is, like, we always knew that the crossover was allowed. So once a patient progresses on one sort of therapy, what was the time to starting of the subsequent treatment? Either it can be intolerance or it can be progression. So time to first subsequent treatment, that the second treatment was 25.5 months in osimertinib. That was more than 2 years. And in the comparator arm, it was 13.7 months. And again, the hazards being 0.47. And this again was statistically significant. So this simply means that once you start osimertinib, the likelihood or the necessity that we will have to switch the treatment or change the treatment to any other form because of any of the reasons, let it be tolerance, let it be progression, is very less likely if we start the patient upfront on osimertinib. So this is the efficacy, charts based on the PFS and OS. Again, the randomization of PFS we have understood. In the OS arm also, more or less in the arms, it has done significantly better over the standard TKI arms. So osimertinib's PFS benefit was clearly maintained consistently across all the subgroups, demonstrating that it has had superior benefit across all the population, including by the race and across the different mutation types. And of course, the OS also was similar. All the OS subgroups showed a positive benefit in favor of osimertinib, although the magnitude seemed to be different across different subgroups. And this is consistent with the PFS data, which also favored the osimertinib arm. So the synopsis of why do we think that it is important for the patients to receive osimertinib in the first line. So it's about sequencing that. Is it possible, since this is an expensive drug, we should start with some other TKI first, then bring the osimertinib on the second line. So the clear data is that approximately 30% of the patients who would be eligible for osimertinib as second-line treatment for T790M mutation positive non-small cell lung cancer following progression on first line. So only 30% would be eligible. So this is like these patients 3 in 2. These are 10 patients. Out of this 10, only 3 will be eligible to receive second-line osimertinib. How this math goes is like this: approximately 50% of the patients who would be alive, would only be able to get the accurate testing of the T790M. So we cannot predict at the baseline that which subset of the patient would be those patients who can actually be accurately tested for T790M mutation. And if we have started some other TKI, there would be a number of patients who would not reach to the point that they may be fit to get this test done or to receive the medicine. They either will not be eligible for the tissue biopsy, there would be insufficient tissue from the biopsy, or there might be an invalid test result. And of course, we all know that the false negativity of the plasma testing may always not be right. So only 73 to 77% of the patients who have mutated EGFR at the baseline are going to receive a second-line therapy, and they either would die during the first line or receive only a palliative care upon the progression. So EGFR mutation positive non-small cell lung cancer, only about a third patient of the standard of care TKI arm patients will receive osimertinib. So this is what I've explained previously. Again and again, this is the slide that's going to come, that there was only 73% of the patients will receive second line. Out of that, after first line, a few patients are going to die. The residual patients that will be remaining around 60 to 76% only can get the valid result. And out of this valid result, only 50% would be one who would be actually getting the medications. Now, in the FLORA study, when the subset analysis was done, and they tried to understand what is the crossover rates and subsequent second-line therapies for the FLORA experimental arm, they got to see that 68% of the patient actually received a cytotoxic therapy. And 22% of the patient, 29% of the patients received EGFR TK other than osimertinib. So, this sort of, this arm also clearly stated, and this also clearly mentions, or this also clearly describes that, not all the patients, even they were in the trial and they had this opportunity to take osimertinib on progression, they could not take osimertinib. So only 31% of the patients in the experimental arm could not receive second-line therapy. So FLORA comparator arm was reflective of clinical practice, of course, like I mentioned, allowing the patients with disease progression to cross over and receive osimertinib, and the 31% could not receive. So this is more or less repetition of the same slide. Now talking about the real-world study, in which the patients with mutated EGFR non-small cell lung cancer, the risk of not receiving a second-line therapy, that is high. So this was a retrospective study. It was presented as a poster in Esmo Congress in October 1923. So what they did was that the study was of 140 patients who had mutated EGFR. It's a Germany-based study. And 112 patients were, out of this 130, only 112 patients were the candidates for second-line therapy. Out of this, only 30% of the patients did not receive the second-line therapy at all. The reason being the patients refused poor PS or fast progression and death. So 104 patients in the study were treated after accessibility to third generation TKI. Across all the lines of therapy, only 29% were treated with third generation TKI. So more or less what we gather from different studies and even from the follow-up of the FLORA study, only 30% of the patient would be receiving the second, third line TKI. So this is the real world data across the multiple countries. They also confirm the similar clinical practice that only 1/3 of your patients would be receiving second line osimertinib. So this impresses upon, and this emphasizes on that we have to start, and we should prefer starting osimertinib in the first line, because data, survival-wise, benefit-wise, and of course, opportunity-wise, favors osimertinib across the arms. So when I talk about the sequencing, if you start osimertinib, the likelihood of that will switch the line would be at least 18.9 months if you start osimertinib up front. However, if we start the standard of care TKI, that's gefitinib and erlotinib, the progression is usually by the end of 10 to 11 months. The median time is 10.2 months. And then the patients would land into chemotherapy or second line osimertinib, that is only with 30% of the patients. And then that time would be 10 months. So the key messages that I would want to impress upon by this presentation is that osimertinib is the only EGFR TK which has demonstrated a clinically and statistically significant improvement in overall survival. We all know that FLORA trial was the first landmark trial to demonstrate how an EGFR TK has translated PFS into an OS benefit. And osimertinib improved overall survival versus the first generation TKI in untreated mutated EGFR mutated non-small cell lung cancer and T790M mutated non-small cell lung cancer who had progressed on the first line TKIs. And that this is the only EGFR TKI to report statistical significant intracranial activity. It was one of the very important factors, intracranial activity. It is very well tolerated drug at the recommended doses of the 80 milligram. It was even leading to the doses reductions of frequent in the second generation TKIs, that is afatinib and dacomitinib. And sequencing cannot be considered the best strategy because 70% of the patients whom we could start upfront osimertinib are less likely that they would be receiving this drug eventually. So these data, of course, confirm that osimertinib is the first line standard of care in the metastatic EGFR mutated non-small lung cancer. This is the standard NCCN guidelines, as we all know. In exon 19 deleted and exon 21 L858R mutations, osimertinib is preferred therapy. That would be all. Thank you.
Yeah, thank you so much, Dr. Dhyani. And I think you have highlighted a very important point here about how many exactly of our patients are going to really receive osimertinib if we started, upfront. So yeah, that's a brainer for us. So moving on to the next session because we are running a little bit short of time. So the next session is going to be taken up by Dr. Abhishek Raj. Well, he is a unit head. He is a senior consultant, and he is heading the department of medical oncology, hematology, BMT, and CAR-T. And he is working at Sarvodaya Hospital and Research Institute, Faridabad. Also, he's a triathlon, I think, a triathlon athlete. So he's the first amongst us in this meeting, at least. So over to you, Dr. Abhishek Raj. Please invite your panelists as well. Dr. Abhishek, can you hear me? You are not audible.
Yeah. Can you hear
Yes.
me? Yeah. Thank you.
Yeah. So please invite your panelists, sir.
Yeah, I'll do that. Thank you for a kind introduction and thank you for giving me this opportunity to talk about this, completing this session on EGFR mutated lung cancer. So after a very insightful talk by Dr. Aruj and previously by Dr. Shyam, who have already set the tone for EGFR mutated lung cancer. So I'll quickly start by inviting my panelists. Are my slides visible, by the way?
Yes, sir.
Yeah, okay. So my panelists are Dr. Mukesh Bansal, Dr. Pratik Patil, and we have Dr. Piyush Mehta, and we have Dr. Ashwin Rajbhog, and Dr. Palak Bhatt, and Dr. Hitesh Khatwani, and Dr. Deep Shankar. I think most of them are medical oncologists, except Dr. Deep Shankar, who is a radiation oncologist. Is everyone around?
Hello.
Yes,
Yeah,
sir.
good
We
evening.
are. Good
Okay.
evening.
Good evening. Good evening, everyone. So let's start. So what we'll discuss today, some difficult questions, some questions which are related to our day-to-day clinical practice, which may or may not have a clear-cut answer, but they do have a relevance in our practice, particularly in Indian setting. So let's begin. So here we have a 65-year-old female with left thoracic chest pain for 1 month. So she was evaluated. As you can see, she had a left lower lobe lung mass, which was 5.5 centimeter invading the pleura. So there was left pleural thickening and effusion with some mediastinal lymph nodes. Biopsy came out to be adenocarcinoma, TTF1 positive, NAPSIN-A positive. So her staging was CT3 and 3 disease and M1 because of left pleural metastasis. And tumor block was sent for genomic testing and PDL1 assay, which is the standard practice for almost everyone. So let me start with Dr. Mukesh. Is there any other test that you'd like to do, sir, at this point?
So in this case, yeah, I will like to do a PET CT scan and a MRI brain.
MRI brain. So everybody is doing MRI brain upfront, irrespective of the symptoms. Dr. Pratik and Dr. Piyush can take this question.
Yes, Dr. Abhishek. So, yeah, we don't do MRI brain routinely in every patient of stage 4 adenocarcinoma lung. Only if the patient is exhibiting any symptoms of related to brain mets like headache, seizures, or ocular symptoms, then only I do.
Okay, Dr. Piyush, you are following the same. So we have two different answers here. Dr. Mukesh says that he does routinely MRI for everyone. Dr. Pratik says otherwise. Dr. Piyush?
I think Piyush is not here. I think Piyush has not joined.
Okay, so Dr. Ashwin, you can take this question maybe.
Hello, am I audible, sir?
Yeah, you're audible.
Yes, sir. Only in symptomatic patients, sir. Not in
Okay.
routine audit.
Okay. Dr. Palak, or in any difference of opinion, Dr.
I
Palak?
think we I think we should do it routinely for all patients because there is a chance of having asymptomatic brain metastasis.
Yeah.
Yes, sir. Agree that we have seen many asymptomatic brain mets patients, so I prefer to do MRI brain in each and every thing for
Yeah,
patient.
particularly it also decides the kind of therapy you are going to choose upfront. asymptomatic brain metastases are a possibility, and it also probably affects the way we treat our patients, irrespective of whether the patient is oncogene addicted or not. So this was my first question. I think this is what NCCN recommendations also say, that you have to do MRI, at least if it is not possible, at least CT of head with contrast. So PET scan usually covers that, but we know that the sensitivity of MRI is higher. So at our institute, we are following that. We are doing routinely MRI for everyone. so uh, so this is a common situation that we face in our clinical practice, that we usually send NGS, or we've done the biopsy. Maybe the crush smear already comes positive for adenocarcinoma, but the genomic testing will take time. But a lot of patients present with a huge disease burden. So, Dr. Palak, can you take this question? How will you start the treatment? Would you like to wait for the report, or would you straight away start the systemic therapy here?
I usually start straight away chemotherapy, just because with all the investigation, patient's time around 10 to 15 days, it will take all the reports to come. And after that, again, to ask the patient that you have to wait for again 7 to 10 days for NGS to come. So it becomes difficult sometimes to counsel the patient. So I usually prefer to go for chemotherapy first, and once NGS come, then I again counsel them to whether to add immunotherapy or any targeted drugs if available then.
Dr. Itesh, is your practice the same, or will it change if the patient does not have a lot of disease mutation? Disease burden is not there. Would you like to wait for the NGS report, or you would also straight away start with the chemo, or chemo plus immuno, or maybe this paclicarbo bevetizo?
So usually in our practice, we start systemic therapy in most of the patients, unless patient is not reasonably fit. We usually start with the if the patient is fit, we start with the platinum-based doublet. If PS is say borderline, then we start with singlet. But we usually use systemic therapy in most of the patients till the molecular reports are available.
Any taker for Dr. Pratik? Maybe you can take this question, that if the patient, without even waiting for PD-L1 report, do you also routinely add immunotherapy? Now that we have, based on Keynote 189 study, a majority of patients are eligible for pembrolizumab, or maybe even after CheckMate 9LA analysis, you can add Nivo-EP plus chemotherapy. Any takers for that?
Yes, so basically the female in the case is an Indian female, 55 years old, adenocarcinoma. So considering that there is a high propensity for this case for being one of the mutations being positive, I would just like to start her with pemetrexate carboplatin. And then depending upon her genomic testing, I would modify it later. But yes, if a patient is very fit and generally males, smokers with adenocarcinoma, there is a very less likely chance that the genomic testing would be positive. In those patients, I would be counseling them for TPBA, of course. And in especially this part of the country where I'm practicing in Pune, where we don't have any panel patients, usually everyone is paying out of their pockets or insurance. Hardly 20% of the patients would go for TPBA. Mostly all the patients go only for pemetrexate plus carboplatin. And then, of course, depending upon the PD-L1 levels and genomic testing, we alter later.
Okay. So, slightly different take than Dr. Palak and Dr. Hitesh. Just moving on. So you started chemotherapy. So this patient was basically started on pemetrexate and carboplatin. She had good tolerance. She started feeling clinically better. Meanwhile, usually this is what happens, that the mutation result and the PD-L1 analysis is there. So she's EGFR exon 19 deletion positive, and she's PD-L1 55%. Meanwhile, we've already started the patient on pemetrexate carboplatin. So, Dr. Ashwin, you can take this question. Would you be inclined to add pembrolizumab here, based on our data of Keynote 189 and Keynote 044?
No, I think with EGFR exon 19 deletion, I would tend to add osimertinib here for a EGFR targeted therapy rather than going with any immunotherapy.
Dr. Itesh, what's your take?
No, so basically, definitely, I would like to go with osimertinib. Given the data of Flora, I would like to use osimertinib on this patient because patient is sensitizing EGFR mutation.
Yeah, that's very important. That all of the panelists, I think, will agree that it's important to wait for the EGFR exon 19 reports because first of all, here these patients are oncogene addicted and they are the driver mutation is your EGFR mutation. So these are the patients who will not benefit by addition of immunotherapy. So this is where the EGFR mutation will probably override the PDL1 expression. And so that is why we should not be in a hurry to add immunotherapy just because the patient has come out to be adenocarcinoma or even if he's smoker. So you have to wait for the genomic results before you jump to this conclusion. So I think we have discussed this. So what is the practice here? Like Dr. Mukesh can take this question. What will you do? You will interrupt the chemotherapy and switch to osimertinib immediately, or you'll continue chemo and or add osimertinib also to the treatment and use osimertinib as maintenance after 4 cycle, or maybe you continue chemotherapy and maintenance pemetrexed followed by osimertinib. So what is your choice here?
Practically, usually I interrupt the chemotherapy and switch to the TKIs, preferably osimertinib if the patient has financial feasibility or other gefitinib. But according to the guidelines, we can do both the things. If the patient tolerated the chemo well and there is a clinical response, we can continue to complete the chemotherapy and then take a decision on TKI agents.
So would you suppose after 4 cycles, would you continue giving pemetrexed and switch over to osimertinib at progression, or you would add it or stop the chemotherapy at some time?
So usually I interrupt the chemotherapy. But
you do that,
but hypothetically, if there is a situation like this, I will stop the chemotherapy at 4 cycles and then go for the TKI agent.
Dr. Pratik
will not wait for the progression.
Dr. Pratik, what's your practice
Yes,
here?
so same as Dr. Mukesh has quoted that I would continue both pemetrexed carboplatin for 4 cycles with osimertinib and later only pemetrexed and osimertinib after 4 cycles.
So you'll give pemetrexed and osimertinib both after the
No, not as a maintenance, only for the first 4 cycles.
first 4 cycles.
Later only osimertinib to continue.
So you are quoting some study here. You would like to quote some study over here? Any trial on which you are basing this decision on? Dr. Pratik? Okay, maybe Dr. Palak can take this question. What is your practice? This is very important. I think we'll ask all the panelists about this.
So I usually prefer to complete 4 cycles if patient tolerates very well, and then put on maintenance osimertinib. I usually don't interrupt after 1 or 2 cycles. This is what I usually do.
Dr. Ritesh, what is your practice? And Dr. Ashwin also?
So if patient has a sensitizing EGFR mutation, I usually switch to the TKI.
Okay.
Definitely. Again, what was the MRI of the patient brain?
So she does not have any brain metastasis.
Brain mets.
The
Okay,
only
okay.
type of metastasis was your
So
pleura.
if finance is no issues, then osimertinib. I will switch to osimertinib.
We are talking in an ideal world scenario. If the patient
Yeah. Then definitely I will switch to osimertinib because as we have seen that only 1/3 of the patients receive in second line. So why to wait for that? So best drug first, definitely. And again, she is an relatively elderly female, 65 years female. That is what I remember from your case. So better to give the TKI to this patient.
Excellent.
Yeah.
Dr. Ashwin.
Abhishek, Dr. Sham here. Can I say a word?
Please, sir. Please, sir. I was about to ask you the question only.
No. So, we look at the Flora 2 study.
Yeah, I was about to come to that, sir. Please highlight, sir.
No. So I think as per the trial design, so after having given a combination of carbopem and osimertinib, so in the maintenance, they continue both pemetrexed and osimertinib. So I think, and the data, though preliminary, is promising. And I think we are giving a combination of all three initially, followed by 2 in the maintenance.
Yes, sir. I think Flora 2 has got the best PFS out of all. We don't have the OS data yet. but the PFS was 25 months, and the second best PFS is by Flora, which is 18 months. So the PFS data is really encouraging, sir. But my concern is that a couple of my patients have developed some bad renal toxicities on pemetrexed maintenance. If they have been given previously, and like somebody was saying that they try to switch it at the time of progression. So yes, it does come at a risk of higher toxicity, sir. What is your experience, sir, with pemetrexed maintenance in some of the patients, some toxicities?
No, I think so. We've had patients who've taken pemetrexed for even 2 years or longer. So we haven't encountered that, but yes, the combination of EGFR TKI with pemetrexed may enhance the possibility of that toxicity. So
Right.
of course, to be very careful watching these patients. So
Right.
I mean, look at I mean, I was surprised to see since we had this onconephrology conference,
Right.
the TKIs and the EGFR or the ALK. I mean, they have up to 20 to 30% renal toxicity data.
Right,
So I
sir.
think we should be careful about all this.
Yes, sir. Particularly with these TKIs, your osimertinib and all, the chances of interstitial lung disease is also a concern. And particularly, I'll be showing just in some of the slides that there is often tendency by some doctors that maybe they are very keen to initiate immunotherapy without even seeing the PD-L1 report. And later on, when they are switching the patient to osimertinib, there are reports that these patients develop more severe lung toxicities if they have been previously treated with immune checkpoint inhibitors. So I think the house is that maybe both the strategy is correct, that maybe you can stop the chemotherapy, patient is 65 year, switch to osimertinib, or you can combine, considering the excellent PFS data of Flora 2, and osimertinib is a relatively gentler drug. You can maybe give combination osimertinib plus pem carbo and then continue maintenance. So moving on. So just what I was mentioning, that just looking at a PD-L1 report and jumping to add immunotherapy may not be a very good idea, because it does not, there is no evidence that it improves outcomes in these patients. One may argue that ABCP did include the ABCP trial, your IMPAR 150 trial. It did include patients with EGFR mutated patients, but the numbers were very less. And the patients that were included, they had already progressed after they had received osimertinib or first generation or second generation TKI. Those were the only patients who were included in that study. So this is what the inclusion criteria says, that patients with EGFR or ALK genomic alterations were included if they had disease progression with or unacceptable side effects from treatment with one approved TKI. So this is something that is reported, that there are severe immune-related adverse events are common with sequential PD-L1 blockade and osimertinib. This is also published in JAMA, that EGFR TKI-associated interstitial pneumonitis is common in patients who are treated previously with nivolumab. So just coming to, we all know that what are the EGFR mutation testing strategies. So just a brief take on everyone. Dr. Deep Shankar, sorry, I have not included you yet in the picture. So what is the testing methodologies that you are using for EGFR mutation testing whenever you see a patient of lung cancer upfront? Dr. Deep, you are here? Dr. Mukesh, you can take this question maybe.
Sorry, can you repeat the question?
So what is the testing methodology for EGFR or your common mutations that are there in the lung cancer?
We are sending it by NGS panel.
I think most of us are sending by NGS only. And anywhere you're utilizing PCR, maybe where you want your results to be quicker, the turnaround for PCR
actually I am practicing in a tier 2 city, so anyways I have to send to a metropolitan like Delhi, and the time taken is not there's not a big difference. So I am yet to encounter a case where I have sent up by PCR recently in last 2-3 years.
So Dr. Prateek, in a non-metastatic setting, which are the scenarios where you're utilizing PD-L1 testing and EGFR ALK testing? In which stages are where you'll be inclined to use these tests? based on some of the newer data. I think we have now data from new ADORA trial that is there. Dr. Prateek, you are here? Or Dr. Ashwin can take this question, Dr. Palak, anybody can take this question, please. That apart from metastatic setting where you're utilizing your EGFR, ALK, and PD-L1 testing.
Hello. Yeah, so in non-metastatic setting, post-operatively for adjuvant osimertinib, now there is a role. So in those cases, we can, get EGFR testing done. And I think recently even ALK data has come out for adjuvant ALK positive patients.
Okay.
So yeah.
Anybody for ALK testing also?
Yes. We do EGFR, L cross, and PDL1, even in non-metastatic setting, because we have good data for adjuvant ALK also, alectinib in adjuvant setting.
So very nice. This recently published ALINA trial is there that now.
ALINA trial, yeah.
After resection of stage 2 and stage 3 patients, I think you can add adjuvant alectinib and there is a DFS benefit with adjuvant alectinib. That data is only for alectinib. Anybody testing PDL1 in the non-metastatic setting or post-CTRT setting, your EGFR ALK testing, anybody is doing?
I think post CTRT, there is a role of PDL1 testing because there's a role of adjuvant durvalumab.
Okay.
After CTRT in localized setting.
Yeah,
But I think durvalumab can be added upfront without PDL1 also, no?
Yeah, true. Yeah.
The approval for durvalumab is irrespective of PDL1, but the subset of patients who had PDL1 more than 1%, they derived the most benefit. Hazard ratio was significant, although the approval is for everybody. There is newer data this time, I think it was presented in ASCO this year, that there are some patients post CTRT, if they are target EGFR mutation positive, and even if you see the data for Pacific, the patients who were EGFR, they had also included patients who were EGFR positive in the post-hoc analysis. Those patients did not derive that much benefit with durvalumab adjuvant therapy. So such patients can be tested, and those patients have shown some initial benefit with addition of osimertinib in the post-CTRT setting as well. So I think in the coming time, that data may come, but still, as of today, post-CTRT, we are not testing anything PDL1 or EGFR ALK. So this is something new that we have now data for neoadjuvant for PDL1 testing. It's regardless of PDL1 testing, you can add nivolumab plus chemo. In adjuvant, as Dr. Mukesh rightly said, that EGFR testing is to be done for 1B to 3A. The maximum benefit is seen in stage 2 to 3A. ALK positive, ALINA trial is there. And if PDL1 is positive in stage 2, 3A, after surgery, chemo followed by atezolizumab can be given. Stage 3 unresectable, again, I said there is some data coming, so you have to do an EGFR testing. So this is the landscape of atypical EGFR mutation. I think Dr. Sham talked about exon 20 insertion mutation. These are some of the atypical EGFR mutations that can be detected. I'll skip this. So this patient was started on osimertinib ATMG OD after stopping further chemotherapy. After 6 months, PET-CT was suggestive of good PR. She was continued without any major toxicity. So this is what the treatment guidelines are there. As we mentioned that osimertinib or chemo plus osimertinib is an option. Then we have options of first generation and second generation TKI. Is there any scenario apart from financial considerations you will consider the patient for first or second generation TKIs? Dr. Prateek or Dr. Mukesh can take this question.
Hello. Sorry. There was some network issue, sir. Can you please?
I was saying that is there any scenario where you would consider first or second generation TKI upfront for EGFR classical mutation, your exon 19 and your L858R?
You mean combination?
No, not combination. Just anything. Combination or your just single agent arlotinib, jaftinib.
Yeah, obviously, most of the patients are not financially feasible. Osimertinib is not financially feasible, and we are still using jeftinib and afatinib. And in the mutations like L861Q, I think afatinib is a good choice. Although osimertinib can still be given, but afatinib is a good choice in these kind of patients.
Also for some of the uncommon mutation, afatinib is a good choice.
Or
Yes.
uncommon mutations, yeah.
Yeah.
I think most of us will agree. So this is the data. I think this has already been discussed. I'll skip this. Flora 2, which sir was mentioning about, that the patient is given induction followed by maintenance osimertinib plus pemetrexed compared to osimertinib. So this is the excellent data for PFS. So just let me ask Dr. Deep now. What would be your treatment approach in this patient if brain MRI shows, number one, isolated CNS metastatic lesion, which is asymptomatic? Number two, you can take this question and you can answer for all the four questions, sir. Dr. Deep.
Yeah, so for the first one, if this patient has isolated CNS metastatic lesion asymptomatic, I would like to go for radiotherapy, stereotactic radiosurgery. Secondly, if there is multiple small metastases but asymptomatic, um, it's quite a dicey area. But then, uh, since the patient is asymptomatic, then maybe some other systemic agent can be added. Symptomatic brain metastasis, obviously solitary. Again, there is role of stereotactic radiosurgery, in which we can give ablative dose of radiotherapy. And again, in the last one, symptomatic CNS metastasis extensive, then whole brain RT with hippocampal avoidance. So we spare the hippocampus and give whole brain radiotherapy in case of symptomatic CNS extensive metastasis.
Yeah, thank you for your input, sir. Any other approach here? Any other panelist? I think majority of the panelists will agree with this. I think isolated CNS metastasis or even multiple small asymptomatic, the CNS PFS rates with osimertinib is excellent. I think we can straight away start the patients on this. But if the patient has associated lot of edema or symptomatic diseases there, I think probably we will discuss the case in tumor board and refer to our radiation oncology colleague. Any difference in opinion?
Yeah, Dr. Mukesh.
Yes,
In
sir.
symptomatic CNS met solitary, I think we can go for surgical excision of the isolated met also.
Yes, that is yes.
And do we? I have a question also actually. Do we need to follow that with the whole brain RT, or we can, if there is complete excision, we can go to our systemic therapy?
Dr. Deep, you can take this question.
So if the surgical excision has been done, so we can actually give stereotactic radiosurgery to the post-operative site.
Okay.
So that has good results. We need to combine it with stereotactic radiosurgery even after surgery has been done.
So radiation is mandatory. We should not be skipping.
It
We
has
should not be
better.
skipping
It has better outcome.
Okay. Thank you.
Okay. So yes, so these are my take. So this is the NCCN guideline that we know that 20% of metastatic NSCLC do have brain metastasis at initial diagnosis, and 60 to 70% eventually develop. They are usually treated with osimertinib if EGFR mutation is positive. So this is the data from Flora that you can see that the patients, they have got excellent CNS PFS rates, irrespective of CNS metastasis present or not. And similar kind of result is also seen in Flora 2. In Flora 2 also, the risk of CNS progression is lesser if the patient has been treated with both chemotherapy as well as the osimertinib. So this is the PFS summary for EGFR treated patient. I think there is some issue with the slide, but this is what the osimertinib is. It is 18.9, 14.7 months was for Archer, and these are for your first and second generation TKIs. So now this patient comes back after completing 24 months of osimertinib. She did not have brain metastasis at baseline. Now patient presents with liver and bone metastasis. What is the approach? Dr. Mukesh, what would you like to do here? Would you re-biopsy or would you test any? Would you routinely send this patient for NGS if everything is available to?
I will like to do a re-biopsy if feasible, and if the biopsies.
What could be your reasons for doing a re-biopsy? Like apart from proving that okay, it's malignancy.
I think we can check the EGFR mutation status although they are mostly stable mutations, but we can come to know of any uncommon mutations or any other mutation developing.
Okay. Dr. Pratik, you can take this question. Would you routinely rebiopsy, and what information you will gather from the rebiopsy? Dr. Ashwin can take this.
So definitely we'll rebiopsy.
Right.
First, to prove metastatic. Apart from that, to see any other mutations, I think MET mutation is quite common in
So
patients.
so
So
histologic
we can check that if
transformation.
that is positive.
Yes,
Yeah, and
excellent.
apart from the transformation, yes, either it is commerce cell or small cell. So I think three things we can check.
Yes, sir. Anything we gain by doing NGS at this point? What information we are going to get from the NGS, and how will it affect our treatment approaches at this point of time?
So again, NGS would redefine if there are any other mutations. Like as I told, the MET mutation is quite common. Apart from that, any other uncommon mutations which we can target in future if we exhaust the later lines of treatments. I think those things we can.
Okay, a quick question to Dr. Hitesh. So this patient was absolutely fine, no liver bone metastasis, just a single site progression in the liver. Just one new metastasis is seen in the liver, which you have done a biopsy. It is again adenocarcinoma. So how will you treat this patient? You have done a PET scan, no other site of disease is there.
If patient is not symptomatic and biopsy proves adenocarcinoma, then I think we can continue with that. And if it is a local site is symptomatic, we can even give site local therapy also. So if liver site is there, we can do we can give local therapy and we can continue with the TKI if there is no new mutation. Then
Anybody want to change his therapy at this point? Or any takers for liquid biopsy? Maybe you have identified some new mutation in the liquid biopsy, or would you like?
Yeah, if there is no mutation, then only, yeah, that is what I told. Yeah.
I think what NCCN says, or what we have been practicing also. Excuse me.
Dr. Abhishek, just a request for the times.
Yeah, just 1 minute. I'll just wind it up. Sorry, I had to take this. So these are just the mechanism of resistance to osimertinib. So if the patient has an oligoprogression, we would probably agree with what Dr. Hitesh said, that maybe give refer to a radiation colleague and do the stereotactic radiation, and then maybe continue with the osimertinib. These are some of the mechanism of resistance to osimertinib. So just a quick word, just two things I would like to ask last. Dr. Palak, if the patient is detected to have EGFR C797X mutation, which can particularly be very common if the patient has been used osimertinib in the second line, what would you do here? Anybody can take this question. Dr. Aditya, you can also take this question.
Yeah. So what's the question, sir?
So if patient progresses on osimertinib, you've done an NGS, you have found to have EGFR C797X mutation. So
Right.
what will you do
I think
here?
we need to look at the cis or the trans, which kind of mutation it is. I think there.
Mutation. It's not very frequent with first line osimertinib treatment, but with later line it is there. And these are exquisitely sensitive to your first line EGFR TKIs. So when the patient has previously been treated with erlotinib, geftinib, they progress to, and you treat the patient with osimertinib, they develop this mutation and they are again sensitive to your erlotinib and geftinib. So there is some data to support that. And
yeah, I think there is some cis or trans C797S mutation as well, where first generation will work, and in the other one, I think it's the osimertinib will work. So I think it's something with cis or trans.
Considering that that there is a limited availability of your amivantamab and your drugs like that, I think that is a good option. It is important to treat that. So just coming to this, that there is So there is a data for a combination of amivantamab following osimertinib progression, that if the patient progresses on osimertinib, you can add amivantamab to chemotherapy. Amivantamab is an interesting drug, and this was something which was presented in Mariposa trial, that if the patient progresses on previous osimertinib, this was a 3-arm study where patients were combined to chemotherapy plus amivantamab, lazertinib, your amivantamab chemotherapy and your chemotherapy alone. So compared to this, you can see here that the results in both ami laser and ami chemotherapy is similar, and it is much superior to utilizing chemotherapy in the second line if the patient has progressed on osimertinib. So that is one of the options that is there. The PFS result is excellent. OS data is still awaited. And I think most of the subgroups and even the more resistant, your L858R mutation patients, they are also responding with a very, very good hazard ratio for PFS that is there. I think with that, I will conclude my panel discussion. I would like to thank all my panelists for excellent insights. Thank you, Dr. Aditya, and thank you, Dr. Shyam, sir, for your insight as well. Thank you.
I will come straight to the presentation. The topic allotted to me is how I treat extensive stage small cell carcinoma lung with durvalumab. What is the real world experience and where are we as of now? As we all know that getting advanced cancer diagnosis and that to extensive stage small cell carcinoma lung, it's not only devastating for the patients, it's actually devastating for the entire family. The challenges which this patient faces, they are not only physical, they are emotional, they are psychological, they are spiritual, and above all, they are financial. Over the last couple of years, we have seen a paradigm shift as far as management of extensive stage small cell carcinoma lung, because we know that this is one of the lethal cancer to have. I will present a case in which Mr. X, 35-year-old gentleman, in June 2021, he was evaluated for the complaints of change in voice, which slowly progressed to aphonia and dysphonia. He was not having any comorbidities, he was a chronic smoker. Initially, as in routine clinical practice, the majority of patients of this complaints will go to the ENT specialist first, and they diagnose that patient is having a vocal cord palsy. Patient underwent a CT scan of the brain, head and neck, and chest. In the CT scan of the chest, which was done in August 2021, there was a small enhancing soft tissue with surrounding fibrosis in the left apical segment. There was multiple enlarged conglomeratal necrotic lymph nodes in the left hilar, paratracheal, and paraesophageal region. There was an orthopulmonary window forming a nodal mass compressing the left pulmonary artery. Further management, medical oncologist opinion was also taken in this, and based on the CT scan, patient was started on ATT initially, but condition worsened. Patient have not improved on ATT, and patient had an episode of seizure in September 2021, and he was started on anti-epileptic drugs. Follow-up MRI brain was done. MRI picked up that patient is having a 2 into 1.9 into 1.7 centimeter marginally enhancing intraaxial lesion in the right temporal lobe with mild surrounding edema without appreciable mass effect. Multiple subcentimetric sized lesions in bilateral temporal and left frontoparietal occipital lobes were also seen. HRCT chest picked up that patient is having a spaceomer lesion in the left upper lobe with a mediastinal extension and encasement of the left pulmonary artery. There is a mediastinal lymph node along with that, and there is a consolidation in the left upper lobe. PET scan was contemplated because the medical oncologist immediately they advised a whole body PET scan in October 2021, and this was the image up front, which is showing that the patient is having a mass sitting in the lung. These are the images, and these are MRI brain images also, which is showing that there is a brain metastasis. Biopsy was done as a diagnostic workup, and it was picked up that patient is having a small cell neuroendocrine carcinoma with a PD-L1 TPS score of 3.24%. The final diagnosis was established that patient is having an extensive stage small cell carcinoma lung with a upfront brain mets. What are the next steps? So obviously, we have to discuss this patient is a multidisciplinary tumor board. The options were discussed whether to go ahead with brain radiation therapy followed by systemic therapy, or should we go ahead with systemic chemotherapy directly upfront, or chemoimmunotherapy should be considered in this type of scenario. The body of literature says that treating brain metastasis, there are some principles which you have to follow. This is based on the treatment of brain metastasis in small cell carcinoma lung and decision making amongst the multidisciplinary panel of European experts, which have concluded these 4 facts: that if the patient is asymptomatic upfront, chemotherapy alone is the most common recommendation for the first line treatment. The patients who are having a asymptomatic brain metastasis with a limited volume of brain mets, higher preference for chemotherapy without whole brain RT is there. For those patients who are symptomatic, whole brain radiation therapy followed by a chemotherapy was recommended, which was most commonly used. And symptomatic patient with limited extent of brain mets, some experts choose stereotactic radiation therapy as an alternative to whole brain radiation therapy because there are some side effects which can happen with whole brain radiation therapy in form of cognitive decline. This is what NCCN guidelines states, that those patients are in good performance and without any localized symptomatic sites or brain metastasis, systemic combination chemotherapy, including supportive care, should be considered in good performance status patients. For those patients who are having a poor performance status, individualized therapy, including supportive care, is to be done. And those patients of extensive stage small cell carcinoma with the localized symptomatic sites in form of SPC obstruction or lobar obstruction or bony metastasis, symptomatic therapy with radiation therapy to the symptomatic sites. And if high risk of fracture is there, then we have to consider orthopedic stabilization followed by palliative external beam radiation therapy. For those patients who are having a spinal cord compression, impending spinal cord compression, RT to the symptomatic sites before systemic therapy unless immediate systemic therapy is required. For extensive stage small cell carcinoma, with brain mets, we have to see whether they are asymptomatic or symptomatic. If they are asymptomatic, we consider systemic therapy before initiating brain RT. For symptomatic patients, brain RT before systemic therapy unless immediate systemic therapy is indicated. So last couple of decades, we have seen that the median overall survival, in spite of various combination of chemotherapy, was hovering around 9 to 10 months by and large. So this patients of extensive stage small cell carcinoma carries a dismal prognosis. Majority of patients will succumb to their illness less than 1 year of the diagnosis. Patient was started on chemotherapy. In this case, obviously, we know that etoposide plus platinum-based combination is the standard of care. Patient have received 30 gray 10 fractions to whole brain radiation with hippocampal sparing to decrease the risk of cognitive decline, followed by 9 gray 3 fractions to gross lesions. And now we know that we are having multiple trials in the upfront setting of extensive small cell carcinoma in which chemoimmunotherapy has been tried and which is positive trials. There are 2 IO combination with chemotherapy which is approved by US FDA, that is atezolizumab plus etoposide and carboplatin. Other combination is durvalumab plus etoposide plus carboplatin, or you can use etoposide plus cisplatin with durvalumab for 4 cycles, followed by durvalumab maintenance, in which the duration of durvalumab will be 4 weekly till progression or acceptable toxicity. Both these are category 1 recommendation. We have to choose the decision based on the patient's merit. Consultative thoracic RT is beneficial for selected set of extensive small cell carcinoma with a complete response or good response to systemic therapy, especially with a residual thoracic disease with a very low bulk extrathoracic metastatic disease. Studies have shown or demonstrated that consultative thoracic RT up to definitive dose is well tolerated, results in fewer symptomatic chest recurrences, and thus improves the long-term survival in some patient. Chemoimmunotherapy, the patient was started on chemotherapy after 2 cycles, and 3rd cycle was given along with durvalumab at the dose of 1,500 milligram every month. So what is the rationale of finding immunotherapy in these type of scenarios? So immunotherapy plays a role in eliciting an anti-cancer response by modulating the patient's immune response of the tumor. There is a high mutational burden of small cell carcinoma may allow these tumors to be susceptible to immunotherapy. And the timing of immunotherapy in relation to other therapies, in particular chemotherapy, is critical to allowing disease control and the development of a sustained immune response. The Casimir trial was the first and only approved regimen in extensive stage small cell carcinoma to use up to 6 cycles of etoposide platinum in control arm, and use of cisplatin or carboplatin can be used. So this is the only trial which have used both platinums, cisplatin or carboplatin. There was a flexibility of using platinum in this trial. Newly diagnosed patients of extensive small cell carcinoma, approximately 800 odd patients were taken into consideration, and majority of patients were having a good performance status of 0 or 1, the life expectancy of greater than 3 months, and at least 1 target lesion as assessed by RECIST 1.1 criteria, and they were stratified based on the cisplatin or carboplatin. So this was a 3-arm trial in which 1:1:1 randomization was taken into consideration. There was induction phase in which Imfinzi or durvalumab plus EP was used for 4 cycles, Q3 weekly, and those patients who are having a stable response or a stable disease or a partial response or a complete response, they are started on durvalumab maintenance Q4 weekly, and it was continued till progression or an acceptable toxicity. It was compared with EP, which was investigator choice of cisplatin or carboplatin was used. 4 to 6 cycles, up to 6 cycles were allowed. And it was also compared with Imfinzi plus EP, 4 cycles in investigation agents, 5 cycles followed by Imfinzi maintenance. The primary endpoint of this trial was overall survival. The key secondary endpoints were PFS, objective response rate, OS at 18 months, PFS at 6 and 12 months, and health rated quality of life reported by the patients. So Caspian trial allowed asymptomatic or treated brain mets upfront, and in the control arm allowed for the 6 cycles of chemotherapy and PCI as per investigator's discretion. So if we compare it with the atezolizumab trial, which was Empower 133 head-on, this is a very important slide. So all comers, there was no biomarker selection for Caspian trial in which durvalumab was used, and same holds good for Empower 133. Untreated brain mets were excluded in atezolizumab trial, that is Empower 133, but they were included in Caspian trial. PCI allowed in the control arm in Caspian trial, and it was only in the 10% of patients with Empower 133. PCI allowed in the experimental arm were excluded in Caspian trial, and it was 10% in Empower 133 trial. Up to 6 cycles of chemotherapy in the control arm was allowed in Caspian trial, but it was not allowed in Empower 133 of atezolizumab trial, and cisplatin patients were included only in Caspian trial. So those patients in which atezolizumab was used, it was only carboplatin. The flexibility of using platinum was there only with Caspian trials. So Caspian trial, by and large, study includes the inclusion criteria, which is reflective of a real-world clinical practice, allowed treatment with either cisplatin or carboplatin, and included patients with either asymptomatic treated, untreated, or treated brain mets, and compared against up to 6 cycles of chemotherapy with an optional PCI in the experimental arm. Silence was of at Caspian trial designed the durvalumab 1500 mg flat dose plus platinum etoposide 3 weekly for 4 cycles in the initial induction phase, followed by durvalumab 1500 mg 4 weekly until progression as a maintenance was used. Choice of platinum was allowed, either cisplatin or carboplatin, in line with the real-world practice. Overall survival was the final endpoint. Ultimately, we want our patient to live longer and live better in this highly lethal disease. Control arm could receive up to 6 cycles of platinum etoposide in line with the real-world practices. An optional PCI, that is prophylactic cranial radiation, was allowed only in the control arm in the maintenance phase and not during the durvalumab maintenance. Asymptomatic as well as treated stable brain mets were included in Caspian trial, which was a key highlight feature of this trial. Look at the PFS advantage with this drug. So PFS was not formally tested for statistical significance, but 56.8% of patients in the control arm received 6 cycles of EP. At 1 year, 17.9% were progression-free, and at 2 years, 11% were progression-free. So look at the landmark PFS. The median PFS was 5.1 months as compared to 5.4 months with EP, with hazard ratio 0.80. But 6 months, the PFS percentage, if you can see for the Caspian trial, the experimental arm, that is Dura plus EP, it was 45.4 months. 12 months, it is 7.9, which is more than tripling of as compared to the EP arm. 18 months is 13.9, and 24 months, that is 2 years, also 11% of the patients were progression-free. This is a huge landmark because in the prior slides, I've shown that majority of patients were not able to cross 1 year with chemotherapy combination upfront. When you use Dura plus EP, 11% of the patients were progression-free at 2 years. So majority of patients who were progression-free at 1 year remained progression-free even after 2 years. This is what came out from this slide. Durvalumab plus EP in the first and only approved immuno-oncology drug combination with chemotherapy demonstrated a statistically significant and sustained improvement of overall survival versus EP alone at 12 months, 24 months, and 36 months too. The 3 years overall survival analysis in the Caspian trial of a median duration follow-up of 39.4 months. As you can see, the median was 12.9 months as compared to 10.5 months with EP alone, and hazard ratio is 0.71. Lesser the hazard ratio, better is the experimental arm, and the p-value and the confidence interval was also statistically significant. There are 3 times more patients alive with Durva plus EP as compared to EP alone at 3 years. The 17.6% of the patients were alive at 3-year landmark as compared to just 5.8% of the patients which are alive in the control arm. Durvalumab plus EP improved the estimated percentage of the patient alive with the 3 times more patients alive at 3 years versus EP, that is 17.6 vis-a-vis 5.8% with the control arm. There's a clear separation of the curves, which is sustained with a notable flattening of the curve observed at 27 months onwards, with further supports a sustained long-term oral survival benefit. As you can see at the tail end of this curve, which is nearly parallel to the x-axis. At 3 years, OS benefit consistently favored DUA plus EV across the pre-specified subgroup that are reflective of clinical practice in extensive stage small cell carcinoma lung. As you can see in the Norris plot, all the dots are on the right side of line of unity, no matter whether patients are having male or female, or patients are having a good hormone status, or those patients who are smoker or non-smoker, whether upfront brain mets were there or not. All the patients have got benefit with this immuno-oncology drug combination with chemo. So DURVA plus EP was evaluated in the key patient subgroup reflective of clinical practice in extensive small cell carcinoma lung. Cisplatin or carboplatin eligible patients were included. Patients over 65 years of age also got benefit, and former or active smokers were having benefit, and patients with brain mets and CNS metastases upfront were also taken into consideration, and they also got benefit this combination. The confirmed objective response rate in DURVA plus EP versus EV, as you can see, 2-year confirmed objective response rate analysis in Caspian trial, it was 67.9% with DURVA plus EV as compared to 58.0% with EP. The odds ratio was 1.53 in favor of the experimental arm. 24 months duration of response analysis in the Caspian trial, with the median duration of response was 5.1 month as compared to 5.1 with EP, but there is a long-term durable response. Ultimately, we want our patients to live longer and live better, and we want to keep these patients as good as possible for as long as possible within limitation of science. And there is 3 times more patients remaining in response at 24 months with DURVA EP as compared to EP alone. The Caspian study, the OS was the primary endpoint. And what about the brain mets upfront? DURVA plus EP consistently improved the overall survival benefit as compared to the EP, regardless of presence of baseline brain mets. With brain mets, the hazard ratio is 0.79, and without brain mets, the hazard ratio was 0.76. So as I already mentioned, that lesser the hazard ratio, better is the experimental arm. That means without brain mets, the patients are faring better, but those with brain mets also, it is more or less better response over there. The median overall survival with brain mets was 11.7 months, and median overall survival was 12.9 months without brain mets upfront. So OS and POS benefit with first-line durvalumab plus EP are maintained irrespective of presence of brain mets upfront, further supporting its standard of care use. In this patient, follow-up PET scan were done in January 2022, and patient have completed 18 cycles of radiation therapy and 3 cycles of chemo and 3 cycles of chemotherapy by that time, and this is what's the response radiologically. So these patients have responded radiologically, clinically also. Treatment was continued, 18 cycles of radiation therapy, 6 cycles of chemo and immunotherapy, 10 cycles patient have received by this time. And in April 2022, there was a decrease in the size of the photopenic areas in the right parieto-occipital region of the brain. There is a decrease in the metabolic inactive minimal soft tissue thickening in the AP window, as there is a encasing of mild left pulmonary artery was there, and no metabolic activity is elsewhere in the scan. So by and large, this is what we have to remember, that Imfinzi, which is durvalumab, is the only IO with a clinical trial data supporting 2-4 weekly maintenance dose administration schedule for the extensive stage small cell carcinoma lung. Induction cycles are there, 4 cycles in which 3 weekly durvalumab is used at a fixed dose of 1,500 milligram, along with etoposide and platinum, either cisplatin or carboplatin can be used. And those patients who are having a responsive disease and they were not progressed after 4 cycles, they were started on maintenance and it was continued at the dose of 1,500 milligram fixed dose Q4 weekly until disease progression or acceptable toxicity. The Caspian trial demonstrated that Imfinzi can be administered Q3 weekly with EP and Q4 weekly as a maintenance alone. Imfinzi plus EP is more cost effective than Atizo plus EP for the treatment of extensive small cell carcinoma lung. So this was checked through the discounted incremental quality and life years gain, and it has shown that despite long-term uncertainty, 3-year also data provides additional confidence in the estimated incremental benefit of Imfinzi plus EP alone, and demonstrated additional benefit versus atezolizumab. So by and large, to conclude, durvalumab plus EP is the new standard of care in the first-line treatment of extensive small cell carcinoma lung. The first-line durvalumab plus EP has shown sustained improvement in overall survival benefit compared with the robust control arm that is reflective of a real-world scenario by allowing up to 6 cycles of EP and the use of PCI as compared to the results from the etocarbo study of Empower 133. Durva is the only IO that provides flexibility of choosing the cisplatin or carboplatin along with the epitope. Benefit of Durva plus EP was observed across all subgroups, includes the brain met subgroup also. More than 17% of the patients on Durva plus EP are surviving even after 3 years, showing a prolonged survival benefit. Infancy plus EP provides a higher response rates and demonstrated ongoing response at 2 years in 3 times more patients than EP alone. Durvalumab offers a convenient once monthly dosing regimen in the maintenance phase, and safety findings remains consistent with the known safety profile of Durva plus EP. So I think message loud and clear that in stage 4 for extensive stage small cell carcinoma lung, in which we know that is a highly lethal disease, ultimate aim is that we have to keep these patients as good as possible for as long as possible within limitation of science. And the dictum in advanced stage extensive small cell carcinoma lung is cure sometimes, treat often, and comfort always. I think message is loud and clear. Thank you very much for the patient listening. Over to organizers, please.
Yeah, thank you, Dr. Nagendra, for a wonderful insight on the role of immuno with chemo and especially how Durva is changing the landscape in the management of extensive stage SCLC. So I think Sham sir is also here. Sham sir. So
I'm here.
any insights, sir? Durva with chemo?
Yeah, sure. I think we heard the previous speaker on Atizo. So I think the immune oncology drugs are here to add to the efficacy of chemotherapy in patients with extensive stage lung cancer. And I think it has become the standard of care for patients with small cell lung cancer.
So, Dr. Nagendra, how about those mutations where immuno is unlikely to work? Like we just had a discussion with Dr. Chandra that STK11 and KEEP. Are you really worried about, so you want to do NGS upfront in everyone, or it is just for prognostication, or we just continue and stick to the same?
Right. So for NSCLC, like adeno or squamous or NOS subtype, we have to do NGS upfront if to find out any actionable mutations. As you correctly mentioned that the KEEP1, the STK11, the KRAS mutations, those mutations right now the NeoEP trial is there, which have shown that these patients we can select based on this. But right now the data is not concrete enough to say so that we can use the immuno-oncology like IO combination in this type of scenario. But yes, this is a food for the thought. In next couple of years, there are many more trials which are going to come in which IO are combined upfront. But coming to extensive small cell carcinoma lung, NGS may not be of much use because these patients there is no actionability as far as extensive small cell carcinoma lung is there. Only those patients like which post-osimertinib progression is there and there is a histology transformation, then in those scenarios NGS may be of some use because there are some patients in which histology transformation also happens from NSCLC to small cell. But in upfront setting for extensive small cell carcinoma lung, I think NGS may not be of much value as of now. I think Dr. Shamsar is there, if we can throw light on that.
No, I think I concur with you on this aspect. And I think we are not asking for NGS in patients with small cell lung cancer. So irrespective of the PDL1 testing or any other report, so by and large, all patients are subjected to chemo and immune drug. So I think, and we do have patients who are doing quite well beyond a year and a half. But yes, we are looking out for a patient who could, go on like 15-20% beyond 2 years and 3 years. So I think, but the data is strong to sort of support the use of these drugs.
So I think down the lane we might get those kind of subset analysis even from small cell where they have gone to find these these mutations, and maybe down the lane we'll be having those kind of data in this SLED subgroup. So that is what my contention was, asking the question here, that if those kind of mutations carry a poor prognostic impact in NSCLC, I don't think we do have any data yet. Maybe down the lane we will. So we should be doing NGS CGP mostly in all the NSCLC patient upfront, I think.
NSCLC, yes.
Yeah.
But not in extensive stage, at the moment.
Yes, not.
NSCLC, yes. Agreed.
Absolutely right, sir.
So, Dr. Nagendra, thank you so much for this wonderful thoughts on your Durvalumab. And with this, I would like to ask Shyam sir to give some key takeaways from the entire meeting, and then we'll wrap it up.
So first of all, congratulations to you for organizing this important, webinar on lung cancer. So I think 3 hours were certainly not enough because there are so many untouched topics here which need attention. But yes, I think starting with the diagnostics in terms of trying to understand the genetic landscape and going on to, the EGFR mutations, the old ones and the new ones, and how to really address them was taken care of in the lectures and in the panel discussion. And then, of course, for patients who don't have these actionable mutations, the issue of IU-IU combination was, adequately discussed. So I think that data is coming up very strong, and a lot of physicians perhaps are switching on to IU-IU along with chemo based on the 9LA. So I think it's a very fast moving field because this ASCO had the role for EGFR inhibition post CTRT, which has become the standard of care. And I believe the neoadjuvant was also touched very briefly, although you didn't have a dedicated, talk, or since the time was short, for the neoadjuvant immune oncology drug in patients who are stage 3, who are potentially operable. So I think a lot of new things are happening. I think even amivantamab post osimertinib was touched, and I think there is enough data to support the use. I think C797S was also touched post osimertinib, and this reminds me, I think we only saw that patient today who is doing extremely well post osimertinib on gefitinib with chemo. So I think there are a lot of takeaways because lung cancer has become so vast. It is not like just giving carbopem versus paclitaxel, which it used to be maybe 15 years ago. So there are so many subsets, and maybe more and more CMEs need to be done to understand and have more information, because you can't imbibe everything in just 3 hours. So I think there is a requirement for more and more sessions and more webinars in each field, including lung cancer. So I think great meeting, and we'll stay between you guys and dinner. So I think it's time. So thank you very much and have a good night.
Thank you so much for these kind words, sir. So thank you, my organizing team, for doing this wonderful CME in the time that we were allotted, and we did it in the required time. I thank all my sponsors and all the organizing team, Abhimanyu, Tarun, and Ekta, so who are there, and I thank all the speakers and all the panelists. So with this, we'll see you on day 2 for the breast update. Thank you and good night.
Thank you, sir. Thank you so much for doing. We'll meet tomorrow. Thank you, sir. Technical support, kindly close the meeting.